Hey Michelle,
Hi, how are you?
I'm good. How are you?
Ready to do this?
How have you been?
Things are good. We're live.
Yeah, we certainly are.
I was just in Philly this past weekend for the American College of Gastro conference. My goodness, it's cold, but I still got my steps in.
Oh, fantastic. Is it really that cold already? Like 40s?
Yeah, in the 30s to 40s. You bet.
Yeah, I I miss that from time to time, but I'm good here in Miami.
Yeah. You ready to get started?
I am.
Okay.
Yeah.
You and I met maybe like a month or two ago, and I
Hmm.
think you and I take care of very similar patients.
I agree.
So maybe if you want to start out with like what is a typical patient that comes to see you who maybe has struggled with their weight and what are some of the concerns that they're expressing to you?
Exactly. And I think, there is where the synergy lies between our practices. It's the two very much go hand in hand, and I'm excited to be discussing this with you today. But with any plastic surgery procedure, weight stability is very important, and it's very important for patients to be at their optimal weight. And if you're having a facelift, a lot of times uh, there are fluctuations in volume of facial tissues with weight gain and weight loss. There are certain areas where I don't think um, weight gain or weight loss has a big impact. For instance, subplatysmal fat. I think that's very much a genetic, hereditary thing. But for the most part, we want patients to be at their ideal, stable, and optimal weight prior to surgery, both for their long-term result and for their safety, both before, during, and after the procedure. So achieving that optimal weight is extremely important when embarking on a facial rejuvenation surgery.
Yeah. And I think, I've worked with many surgeons in the past who have like a BMI cutoff. But as you know, the interesting thing about BMI is it's just based on height and weight. So you may have people that have thin legs, thin arms, but have a lot of, belly fat, and then may also have like a wider neck. So maybe if you can share, like from an anesthesia risk perspective, why is the BMI, in some of your cases, why may it not be all that helpful because of where the body fat's distributed and how it correlates with risk?
Exactly. I think BMI is just one of those things that's a starting point for us to frame our effort around and our guidelines around. But as you mentioned, that's really just two variables, height and weight, and the distribution of body fat can be visceral, it can be above the rectus muscle, so just underneath the skin. And then with regard to that distribution of fat in the face, at some point, if the face is very heavy and then patients undergo a lot of weight loss, then the aesthetics of the face can reflect that, and tissues will sag dramatically after significant amounts of weight loss. And from a safety perspective, we know that um, those patients who have a BMI that falls within a range, and taking that one step further, that um, their protoplasm is appropriate, so that weight distribution is appropriate.
Mhm.
We know that those patients are going to heal better, have less complications, and a much greater safety profile for the procedure itself. Facelift surgery is, I always tell patients, it's 80% what I do in surgery, and the other 20% is really being vigilant about the preoperative preparation for surgery. So making sure that you're optimized in terms of your nutrition, and then being very vigilant and about the postoperative care and ensuring that we have proper healing, and we're not getting any issues with infection or things like that, which is rare in facelift surgery, but nevertheless, uh, we never let our guard down.
Yeah. So you bring up some interesting points when it comes to nutrition and having like an optimal status before surgery to help with the actual surgery, but really with recovery. But how do we even like define optimal nutrition, right? I think so much of the times we look at someone's weight and say, oh, you either look malnourished or you look overly nourished or you look normal. But the reality is, I think just we as healthcare providers probably don't do a great job at doing that because even just checking someone's nutrition labs is only telling us a very small part of that picture, right?
Yeah.
And so just because someone has obesity, what we know is that a lot of people who struggle with obesity, they may be getting calories, but they may not be getting great calories where they're getting the nutrients. And so I have tons of patients with low B12 and vitamin D and all these other things that can, low zinc, all these things that can also impact recovery. But the big one that I think you and I see is like protein calorie malnutrition, particularly in patients who have either had bariatric surgery or who are on these second generation weight loss medications like your GLP-1s, like Ozempic, Wegovy, Zepbound, or Mounjaro. Because as a weight management specialist, what am I doing? I'm shutting down people's appetite. And oftentimes, when we're not as hungry, the last thing we want to eat is protein. And as you know, protein is incredibly important for getting through a surgery, but really the post-op recovery. And again, you're not going to see that on a BMI. So someone's BMI may actually be very favorable for a surgeon, but if we're not looking at like their muscle and kind of a baseline nutrition status, I honestly think we're probably missing a lot of people that could be optimized pre-op.
Absolutely, I couldn't agree more. And so, from your standpoint,
Mhm.
what would be if someone's nutritional status was called into question prior to surgery, someone who's had some of these procedures or been on certain medications, what is briefly some of the workup that you would do to ensure that we've got nutrition where we want
Mhm.
it to be, and also how would you propose optimizing that for those particular patients?
Yeah, and I think even if someone is normal weight, I think everyone should have some sort of like an overall baseline nutrition status. So, are they eating enough calories, but are they getting enough protein? That's always where I start. Protein is the only macronutrient our body needs to survive. It's incredibly important for every aspect of our health. And so that just, starts with doing a dietary recall. What are you eating on a typical day? Oftentimes people, with me, they think they can get away with saying, oh, I have a sandwich or I have some eggs, but I have no clue what that means. So if they say I have eggs, I say, how many eggs do you have in the morning? Are you having the yolk or just the egg white? Are they regular? Are they jumbo? If you're having bread, is it Ezekiel bread or white bread? Because you can, based on what they tell me, if they just have one egg and think that's sufficient, that may be 6 grams of protein. Most women need 80 to 100, and most men it's going to be at least 100 grams of protein a day. And as we get older, and I'm sure the majority of your patients are not in their 20s, they're probably in their fifth to seventh or eighth decade. As we get older, we get what's called anabolic resistance, where we need to eat actually more protein and do more strength training just to minimize some of that muscle loss. So oftentimes as we get older, we need even more. So it really just starts with how much protein are we taking in a day can be a start. Are we getting like fruits and vegetables, whole grains, nuts, seeds? Fiber is also very important. Our gut is our largest immune organ. We have to support a healthy gut microbiome, and the organisms feed off of fiber. So if I want to optimize someone's immune status to minimize post-op issues, I want to make sure they're getting enough fiber. And then I'll check just some basic labs to get a starting point. Very easy. It's standard, just a B12, a folate RBC, a vitamin D, and then if the patient's menstruating or if any reason to believe that they have iron deficiency anemia, I'll check iron, and then plus or minus some other labs based on their other conditions.
Okay. Is prealbumin and albumin something you routinely?
Mhm.
How indicative of that is that of someone's protein status?
Yeah, they're very poor markers, unfortunately. They kind of look at more late stage issues. but those levels can drop in any sort of like inflammatory state. So it's really hard to, get a good picture based on those biomarkers. I think, to date, we don't have a great biomarker on what someone's nutrition status is, unfortunately.
Okay, great. And in
Yeah.
terms of protein optimization, do you have any favorite supplements post-surgery that you routinely recommend?
I guess I got to ask you, like, what does the post-op recovery look like? So with a facelift, what sort of restrictions do they have? Are they able to chew, regular food? Tell me more about the post-op process.
Absolutely. So there are things that I'm very frequently repeating with facelift patients in the post-op recovery, and I think that everyone in this office has sort of been indoctrinated into some tenets that I, hold very close, which is when recovering from any surgery, and basically the things that I do are facelift surgery and rhinoplasty, but I want high protein intake after surgery, and in general, I'm not an expert when it comes to nutrition, but I know that, and correct me if I'm wrong, that animal protein is much more digestible and uh, much better utilized in our guts.
Mhm.
So I encourage a lot of animal protein after surgery. I want to keep, in facelift surgery, I want to keep the salt content down, and I want to keep the fluid intake down because, a lot of patients know that they need to be well hydrated in life, in daily life, but immediately after a facelift, I want patients to drink when they're thirsty, but outside of that, I really want to keep that fluid and sodium intake down because it really does have an impact on their swelling and their recovery in the immediate postoperative period. And um, I see it all the time. Those patients who really listen and
Mhm.
keep the protein intake high and keep the salt and fluid down, their swelling is much um, less significant. And if you can get a jump on your healing early on in the postoperative course, that really sets the stage for the following 3 to 4 weeks and the next month. That um, trajectory is much
Mhm.
better in those particular patients. So those are sort of generalizations, but I want high protein intake, low salt, and low
And
fluids after.
are patients able to chew
They
normally?
are.
Uh-huh.
Yeah, I mean, they will feel. I always tell them it's a lot of common sense after.
Mhm.
Like, we definitely don't want you biting into a hamburger post-op day one. That's not something that's reasonable.
Mhm.
But protein shakes, smoothies, and that's something that we make sure we have in line and something that we provide for our patients in the immediate post-operative period. But it's really just advanced the diet as tolerated,
Mhm.
uh, and a lot of common sense. Like chewing on um, a firm piece of steak post-op day one is not very realistic. But scrambled eggs are wonderful post-op day
Mhm.
one and post-op day two.
Okay, amazing. Yeah, I think when you look at the research between animal and plant-based protein, it's a little bit all over the place. Because you want to get all the essential amino acids, meaning ones that we can't make ourselves, you have to consume. So animal proteins are complete proteins. And if you just have, let's say, beans, it's not going to have all this essential amino acids. But the ways that you can get around it is you combine different ones. So if let's say you're doing a protein shake and it's like a pea-based protein, you can add other ingredients or fine protein powder options that have multiple types of protein that will end up getting you everything you need. So yeah, I mean, I generally recommend a mix of both. I think in general, we eat way too much animal protein. Like when people have, chicken, they may have like 8 or 12 ounces, right? So like a portion is 4 to 6 ounces. Or if people go to a steak restaurant, obviously not post-op, they may be getting like a 16-ounce tomahawk. In general, I think we consume way too much. But post-op, absolutely, you got to find easily digestible options.
Mhm.
So if it's, let's say eggs are amazing, you could even like fold in some cottage cheese and cook it with the cottage cheese, and then you're gonna really double the protein intake. Cottage cheese is a really high protein option, or just like a plain Greek yogurt and maybe mix in like some peanut butter, like a Justin's or Barney's peanut butter will get you another 4 to 8 grams of protein, and a plain Greek yogurt can get you like 16. So that's super easy if someone doesn't feel like, let's say, making a smoothie. When it comes to like the protein shakes out there, a lot of the pre-made ones are ultra processed. I mean, I used to use them all the time in my patients in the hospital, like Ensure or Boost or Premier Protein. Many of them do have artificial sweeteners. So if people can make it, and preferably, make them in advance before surgery, because they're probably going to be tired and not wanting to do it, then you just make a bunch in advance, you freeze some of it, you put some in the fridge, and then it's ready to go. And you can add, so some of my go-tos would be like collagen. So again, it's not, it doesn't have all your essential amino acids, but it's really good for the skin, hair, and nails. So if you added collagen, maybe add some Greek yogurt, some frozen fruit, and some peanut butter, blend that up, and it's very protein dense. Plus you're getting the fiber to support the gut microbiome.
Fantastic. Okay.
Yeah.
Well, I think that's, I definitely learned a lot just then, and something that we'll be counseling our patients on for sure. Dr. Pearlman, a question that comes up pretty frequently is with regard to things like Ozempic. Can you say a few words about, from an anesthetic standpoint, your knowledge on how the time frame that patients should be off that prior to surgery?
Yeah, it's interesting. So it takes the normal stomach about 4 hours to empty, a standard meal. So that would be like an egg sandwich. It takes 4 hours. So on these GLP-1 medications, when we've done gastric emptying studies, it actually looks like for most people, you only get delayed gastric emptying within the first hour after eating. But some people, it's going to be delayed even longer, particularly foods that have a lot of fat. Fat is the macronutrient that delays the gastric emptying the most. So even if you have a normal stomach and you're not on a GLP-1, if you eat a 16-ounce tomahawk steak at night, you're probably going to wake up with steak still in your stomach. Okay. With anesthesia, there have been providers that have had not great outcomes because the person goes in for anesthesia, they're getting an upper endoscopy, they go in with their scope, and the stomach is full of food. It doesn't happen all the time, but it can happen. And this can happen even with people who are not on GLP-1s, who are diabetics with underlying gastroparesis, but it poses a large aspiration risk. And aspiration with anesthesia is a bad, bad problem. So we always want to be on the safer side. So it's going to depend on the facility, on the anesthesiologist. Most people will say skip one dose. So you're at least holding it for, let's say, 7 to 10 days. I've had other surgeons or other facilities that say hold it for a month, which I think is 100% overkill. But I'd say on the safe side, like 7 to 10 days. As they're getting close to surgery, then just cut out, some of that fat and just stay on the lighter end of eating to make sure that everything is emptying properly.
That's great. Yeah, we generally have been telling patients 10 to 14 days prior to surgery. So
Yeah.
great. Well, that's very helpful.
And someone had mentioned here in the comment, is fiber important in addition to protein? I hear anesthesia can slow your GI system. So yes, any sort of anesthesia can slow things down. I think particularly post-op, I imagine they have quite extensive exercise restrictions. When our body doesn't move, it's very common to get constipated. The last thing you want is a major facial surgery, and then you can't go to the bathroom and you're in even more pain. So that's where, adding in the fiber, maybe adding some psyllium or like what Metamucil or fruits and peanut butter into the smoothie can be helpful to make sure you're still getting your fiber. But with the fluid, a little bit restricted, we want to make sure we're aggressive with the bowel regimen.
Yeah.
So there's nothing wrong with like taking Miralax with water or taking a stool softener. Once you're impacted, it's really hard to treat that constipation. So I'm not sure how you normally kind of counsel your patients on the bowel regimen.
Yeah, we've begun to include that with their post-operative instructions, but the combination of limiting fluid, Once in a while, patients have pain, and we do prescribe a very light narcotic for the initial postoperative period if patients are having pain. And as you know, that can cause some constipation as well. So there's definitely a lot of small things that could lead to constipation. So we've learned that counseling our patients about avoiding that is very important, because we don't want any straining after
Hmm.
surgery, whether it's getting up out of a chair, walking up some stairs, or using the restroom. Like, that's all very important stuff. We want to keep that blood pressure low. That the healing is such an important part of recovering from a facelift, and that's a big part of it.
Hmm. So in your patients who were, let's say, on a GLP-1 pre-op, when do you tell them that they can restart it?
Typically 10 to 14 days
Hmm.
after surgery.
Yeah. And that's what I usually tell them as well, because I think they're probably not very hungry. And the last thing I want to do is make it harder for them to get their protein requirement. So usually I just have them message me and tell me how they're feeling so I can help kind of guide them. I think people are sometimes so worried on coming off the medication, but the issue is when you have to be sedentary and you have these restrictions, muscle loss can be pretty profound if people aren't careful.
Yeah, exactly. Especially in that demographic of patients in their
Mhm.
50s, 60s, 70s. We want to hold on to as much of that muscle for as long as we can. So,
Yeah. And I've learned so much about that in the past couple of years. Throughout my training, we never focused on muscle, right? I mean, we didn't really even focus on weight. I learned that in like my 14th year of fellowship when I was mentored by an obesity medicine specialist. But, so much of the time was we focus on weight or the BMI. And just in my perspective, we should be focusing on muscle, right? Because what keeps people at home and not being able to do the stuff they want to do as they get older? It's frailty. It's one little fall and they break a hip
yeah,
and it's over for them.
yep,
So, and it's really hard to gain muscle as we get older. So I see that a lot, unfortunately. But the beautiful thing is there are things that we can do every day,
yeah.
to stimulate the muscle and make sure we're getting protein. And it's even more important when you're planning on having a surgery and through the recovery process.
Okay,
Yeah.
great. Well, I'd love to get into the plastic surgery side of things, but I do have another very important question for you, and I think this is something that you and I have dealt with, is that there are some patients who just don't tolerate the GLP-1s
Hmm.
with their initial attempt at it with some providers. Can you say a few words about those patients who are pretty discouraged because they've um, tried this, and the side effect profile is just too much for them, or they need to get down to a certain weight in order for me to safely and successfully do a
Hmm.
nice procedure for them, and they're just discouraged because of their inability to tolerate the medication.
Yeah, great question. So about 7% of people on the medication stop it because of a side effect. The most common side effects, it is a gut hormone. It affects primarily the gut, but also works in other mechanisms, including reward centers in the brain. It dampens that response, but it slows down the rate at which the stomach empties. And so it can also just change motility of the gut kind of everywhere in the small intestine and the colon, we think. But the main symptoms are heartburn, bloating, nausea, vomiting, diarrhea, or constipation. And sometimes it can be very variable. Usually those symptoms are going to happen within the first 24 to 48 hours after their injection. Those symptoms are going to occur when they start a medication and they usually get better, or when we increase the dose. So there are a couple medications on the market. When people talk about the GLP-1s, most people are thinking about Ozempic, but there are other options. Ozempic is semaglutide. The other name for it is Wegovy, which is for non-diabetics. And then the newer medication on the market is tirzepatide, and that's your Mounjaro and your Zepbound. So we know that actually tirzepatide, so Mounjaro and Zepbound, actually has a favorable side side effect profile, people tend to have less GI side effects. So I always ask someone, okay, you've tried Ozempic. What was the dosing? What were your symptoms? When were they worse? And then in that scenario, I would probably have them trial tirzepatide. It seems to be a little bit better tolerated. I also ask them, were they getting it compounded or were they getting it commercially available? Many people aren't quite sure, but if you're buying it in your doctor's office, it's the compounded version. And it typically is coming in vials. I only use the commercially available option because that way I know what my patients are getting. The compounded formulations, you're kind of, playing Russian roulette there. A lot of times they're adding other compounds to it, and it may not have been an intolerance to the active ingredient. It may have been something else they added to it. So using commercially available options, and then making sure they're on the appropriate medication that may have a more favorable side effect profile. But for me, at least, when you look at the clinical trials, every month they're increasing the dose. So typically, let's say for Ozempic, it starts at 0.25, or let's say Wegovy, 0.25, then 0.5, then 1, then 1.7, then 2.4. So every month they were increasing the dose if the patient tolerated it. In my standpoint, though, that's not how I titrate the dose. I want to have them on an effective medication where they're losing weight, but most importantly, they're preserving muscle mass and we're minimizing side effects. So just because I can go up on the dose does not mean I do. I always go back to the drawing board. I look at their bioimpedance measurements and I look at their muscle mass and I say, I'd rather you lose 4 pounds this month and only 0.5 pounds of muscle than lose 10 pounds and lose 3 pounds of muscle, because muscle is very precious. So I look at the muscle. I look at how much protein are they taking it in. My goal is not to shut down your appetite completely. It's to take out the food noise, allow you to eat less and still feel satisfied. If I start creating food aversions where people don't want to eat, you better believe they're not getting their protein intake. So that's kind of what I'm looking at. So I think we just have to have more nuanced conversations with patients and make sure that they're being supervised by someone who has expertise in the field to say, okay, at 0.25, I did great. Once I bumped it up to 0.5, it was too much. Okay, great. Let's just go back to 0.25. Maybe that's all you needed, to reach your goals.
Hey, fantastic.
Now tell us about Ozempic face, which a lot of people see you for. So I help them lose the weight and then they start having, right, like the temporal wasting and other things. What are some of those things that you see? And do you think it's from Ozempic or just from pretty significant weight loss?
Excellent question. I certainly have my theories, but even with patients who are in their 50s and 60s who are very fit patients, temporal wasting is something that I routinely see in that patient population. So for those people who are listening, temporal wasting is that hollowing that some patients get in this temporal area with age or with weight loss. So patients who are very fit and who are frustrated with sagging of the face and that loss of facial volume, those patients are frustrated. And I tell them, don't ever put your health aside and gain weight just so that your face is a little more plush. We certainly don't want that. Leave the aesthetic restoration of the face to me and continue your vigilance with your health. But rapid weight loss or weight loss in general can lead to that loss of facial volume, so temporal hollowing. And if you look at young patients, if you look at young, beautiful people, the face is very plushly padded. It's cushiony, it's soft in certain areas. Yes, there's contour, but there's a soft and a plushness to that contour of the face. With age, we all have a tendency to lose some of that volume, and things become a little more harsh with age. And we also tend to gain volume in areas where it's not contributing to optimal aesthetics. So for instance, under the chin and under the neck, and we lose that contour and definition of the neckline and the jawline. So Ozempic is a medication that patients lose weight pretty rapidly and successfully with, and the side effect profile of that is the loss of that nice padding to the face, that plushness, that youthful look to the face. So that's sort of where I come in those particular patients. They're very happy with the effectiveness of the medication. They're very happy with their their body habitus and the gains that they've made in that department, but it has quite a bit of a tendency to negatively affect the aesthetics of the face. So that devolumization leads to that loss of plushness and also sagging of facial tissues. That rapid weight loss can cause tissues to sag, and we lose contour, we lose that shape of the jawline, that positioning of the malar eminence of the cheek. And so my job is to really restore that youthful quality and contour to the face. And we've had a lot of success in patients who are on Ozempic in facial rejuvenation surgery. We're using your own tissue, and we're really just repositioning that tissue into a place where it once was on its own. And in doing so, we're restoring that aesthetic, youthful shape to the face. So that, in conjunction with fat grafting, for instance, the temporal areas that are hollow, we need to volumize those areas. And there's a number of ways that we can do that. Facial fat grafting is one of them. There's a bit of variability in the results that I personally have seen with facial fat grafting, particularly in very lean patients. Mm-hmm. But I always tell patients that, listen, it's not our only modality to treat this, number one, and number two, I've never seen a patient get zero benefit from facial fat grafting. So we have a number of ways to restore that plushness to the face. And nothing is, none of these modalities are 100%, but it's something that if you keep working at, we've seen many nice results and very happy patients using these techniques.
What about like injecting filler? Is there a role for like injectables for the temporal loss?
Absolutely. Personally, at the moment, and I know there are some hyaluronic acid fillers that are getting FDA approval for the temporal area. If that may have already happened, I'm not quite sure. But nevertheless, Sculptra is a great product for temporal hollowing. Mm-hmm. And hyaluronic acid fillers, which as I mentioned, is either approved or in the process of getting approved, is also a great option to treat temporal hollowing. So we have none of these options are 100% perfect, but nevertheless moving in an incremental fashion. In plastic surgery and facial rejuvenation surgery, nothing is 100% perfect 100% of the time. So I'm always telling patients, listen, we are really going to move the ball downfield and get a tremendous amount of improvement, lay that foundation, remodel the house. But we might have to add another coat of paint at some point or polish something. And that's the reality of plastic surgery and good facial rejuvenation surgery is you can't always just swing for the fences and assume that you're going to get that home run. Sometimes you're going to get a triple, and then you will be up to bat again, and with smaller procedures be able to continue to advance the objective and get aesthetic improvements.
I love that, remodel the house, because I think many times if we're spending the money, we want it all done all at once and not have to worry about it. But the reality is we're living longer. So if we're getting a facelift at 55 or 60, the reality is we're going to need some touch-ups.
Exactly. And even that's not such a bad, it's not a bad thing. I mean, the initial facelift, so I get this question a lot, and I'm so happy you brought it up. Many patients ask, am I going to have to ever do this again? And I don't have a crystal ball. I don't have all the answers. But what I do tell patients is that if you do need to have this again, the degree to which the amount of correction you'll need at that point will be far less than this initial remodeling. So that's my current stance on that.
Because I think the alternative is you do too much and then it looks way overdone, and then you can never go back. You can
Yeah.
always make adjustments moving forward, and I think I encounter that very similarly with my patients who are on these weight loss medications. Is sometimes people have this notion where, okay, I used a medication to lose weight, now I can come off and maintain all my progress, right?
Mm.
But the reality is, just like after a surgery, with these weight loss medications, our bodies change. And whatever worked for us to lose the weight is oftentimes going to be a different plan just to maintain it. That's the hard part, right? The hard part is not losing it, it's maintaining it. I'd imagine very similar to you. The easy part for you is doing the surgery. The
Mm-hmm.
hard part is the patient's recovery and then the maintenance after that.
Yeah, exactly. And that's a great segue into another question that I get a lot is, what's the ideal age to do a facelift?
Mhm.
And there really is no ideal age. I've had patients who, um, on both ends of the spectrum, where I've had a 36-year-old patient where for some reason, just genetically, she was weight stable. There was no massive weight loss. She just had very premature facial aging, jowling, a lot of laxity in the neck, and she was a candidate, and I was able to help her out, and she's absolutely delighted and has this new vigor and vitality and quality of life. She's obviously the low end of the spectrum, but there are patients who I see in their early 50s who, much to my surprise, they're not a candidate yet, and a lot of that is favorable genetics and patients who've taken very good care of themselves. But determining someone's candidacy really has to do with the clinical evaluation. But in general, the paradigm is shifting for facelift surgeons to do things earlier rather than later, and the reasoning behind that is it's multifaceted. Number one, the younger you are, the better the tissue quality. So a facelift is really, we're working with the building blocks of the face, and more youthful tissue is much stronger, much more durable. The elastin and collagen content of all the tissue layers is of a much higher quality. So the durability of the operation is greater. So we get a much longer lasting, durable result in younger patients. Younger patients, we all heal better when we're younger. So the recovery is much better. And when you're young, when you're on the younger side, the degree of correction that we've got to make is far less. So the ability to really fly under the radar after this surgery and not look drastically different. You really look like you've been on a great vacation, and you've relaxed, and you're feeling great. So the ability to fly under the radar is much better when you're younger. And then, so the combination of those things, healing quicker, being more inconspicuous about having had something done, and the durability of the result, I think, has sort of shifted the paradigm in facelift surgery to do it towards the younger end of the spectrum. Now, that doesn't mean just because you hit age 40 or 45, you're a candidate for a facelift. Again, there's a lot of clinical judgment there. But in general, I prefer doing things earlier.
Yeah, it's fascinating because it's very similar with my patients. If you look at the clinical trials, they always have like an age range, and usually it cuts off, I think, maybe in the 70s. I have patients in their 80s who are on these medications, you know, and so I really have to look at just the overall health status. There are some 80-year-olds who are not candidates, and there are some that are. But I actually prefer to do an intervention, you know, in younger individuals. It's really hard for me to change 60 years worth of
Yeah.
behavior. And if someone already has significant sarcopenia and bone loss, I can absolutely still help them 100%. But sometimes, you know, sooner is better because I want to prevent the muscle loss, right? Not just treat it once it's there.
Yeah.
Once you have, you know, osteoporosis when you're 80, there's only so much
Yeah.
bone you can maintain. So it's really about targeting the younger generation. They may not need a medication per se, but I think everyone can benefit from the nutrition foundation, right? How do we set ourselves up for success for the rest of our life? A big part of that is what we're eating on a daily basis and how we're moving our bodies. Even if we don't enjoy going to the gym, it's how do we incorporate strength training, or if we're on Zoom all the time, get some ankle weights or get a weighted vest, take the stairs at the office. Those little things add up. I think oftentimes we have this mentality, it's all or nothing. And if I can't get to the gym, I'm just not going to go. But it may be just incorporating some resistance band exercises when we're at home. So those little things add up. But it's, you know, a big thing is like, how do we want to spend the last few decades of our life? That's going to be determined by the decisions we make today and tomorrow.
Absolutely. Absolutely. And something you reminded me of is that I'm constantly saying this to my patients: an ounce of prevention is better than a pound of a cure. So if we do the facelift early and there's 20% correction that we're making, I'm able to, by correcting that 20%, I'm also able to prevent or at least control that aging process over the next 1.5 or 2 decades. So again, another reason why doing facelifts earlier is better, in my opinion.
Yeah. So we have someone that has a comment and or question about having a gastric sleeve, losing weight, and having some weight regain. Weight regain absolutely happens, can happen after bariatric surgery. Again, we get what's called metabolic adaptation after we lose weight. Our muscles become more efficient at burning calories. So even if we do the same exercise at a heavier weight compared to a lower weight, we burn less calories at the lower weight. What also happens with GLP-1s or any sort of weight loss program and bariatric surgery is we tend to lose muscle. We can definitely do things like making sure we're getting protein, doing strength training to minimize that. But the reality is most people who are actively losing weight are going to lose some muscle. And in people who are losing anywhere from 50 to 150 pounds with bariatric surgery, muscle loss is very common. So that weight regain doesn't mean that people are binging after surgery. It's that we have a different body after surgery, and that, you know, just to maintain or prevent weight regain, we often have to eat less and move more, you know, more than we ever had to before just to maintain. GLP-1s are incredible tools for post-bariatric weight regain. So even though you may only have part of your stomach, it's a really good tool to help get some of that off before you end up going for a facelift. So hopefully that answered your question.
Great.
Yeah. So, yeah. So I think, you know, what are some things that you're looking forward to as far as like innovative techniques? What's on the horizon? What are some big things going on for the finishing up 2024 and heading into 2025?
Oh gosh. Yeah, you've got me looking ahead. I'm just you know, it's I've always had to repeat to myself that just one patient at a time. We got to take care of one patient at a time and make sure that that patient's got the best seamless care and the best possible result that I can deliver. You know, facelift surgery is a constant evolution. It's a constant learning process. Um, you know, things that I'm doing right now, things that I did a year ago, I've adapted, I've tweaked. I'm constantly trying to think of ways to improve patient outcomes. And I think that's the benefit of really subspecializing in certain aspects of aesthetic surgery is that you really have the ability to uh, have high repetition and see how certain techniques can tweak or affect one individual patient's result and how that might apply to a similar face in the future. So that's the benefit of really having a niche specialization within facial plastic surgery. So I'm just enjoying the uh, blessing of being able to take care of patients and taking it one day at a time.
Love it. Love it. Yeah, I think my sister and I, like initially we wanted to be a jack of all trades. And then we realized, no, we don't. We're really good at what we do. And we just want to find the other really good people who are really good within their specialties. And then everyone wins. Something that my sister and I are actually getting trained in doing is actually female hormones. Maybe we can do an Instagram live on that. All these women, right, when they lose estrogen, their face changes, their skin
Yeah.
changes, their hair changes, all of that. And so I was, prescribing a lot of these GLP-1s for women coming in, gaining that menopause belly and not feeling well, and then developing prediabetes, but I wasn't addressing the underlying estrogen deficiency. So
Yeah.
we're going to be offering more of that comprehensive approach where we're optimizing hormones, minimizing muscle loss, and helping them, reach whatever goals they have for themselves.
Well, that's awesome. Well, thank you, Michelle. I've already learned so much from you, and working with you, and I'm looking forward to having this relationship for many years to come, and really offering our mutual patients the best quality care there is out there.
Love it. Well, thank you so much for joining the Instagram Live, everyone. And post questions either on my site or your site, whatever, and we will do our best to answer whatever we can.
Absolutely. It was great seeing you. I'll catch up with you very
All
soon.
right. Sounds good. Have a great day.
Take care. Bye bye.